These are new technologies, and then eventually there's neural navigation, right? And sometimes the navigation can be in real time together with the MRI images, and you can actually have a more precise stimulation. But neural navigation, you have to be careful because it can actually stimulate the point where you want it to be, but it can follow. Sometimes it can even follow as you move your head, but unfortunately, the spatial resolution of the coil, even the most advanced coils, are not fantastic. They're not like pinpoint accuracy. They are like I would say, maybe 2 to 3 centimeters, plus and minus. Kind of. It's not a focal area. So unfortunately, there are some limitations at TMS, and these coils can be to the extent that some people try to put 2 coils and then try and act about it, and we are activating on the surface of the head. Okay, so there are a lot of coil designs. Okay, this is the electrode. We'll see later the electrode that we have, the sticky electrodes, adhesive electrodes. This is similar to EMG, to nerve conduction, right? Basically, you are recording a muscle twitch, right? And the most effective area in the brain that we can stimulate is something very superficial, very close to the skull, very close to the scalp, and somewhere there is a motor response or muscle twitch, and of course, there must be the motor area, the primary motor area. Okay? And that's where we want to concentrate on. So it's good and bad, but with RTMS, we can actually activate or inhibit other areas. But with single shot TMS, where you want to have a measured response, which we'll show later, then obviously the motor area is the one. Alright? So I just introduced the first concept of something called motor threshold. You know what's threshold, right? Threshold is the lowest intensity that you can deliver to obtain the smallest visible response. So TMS, interestingly, there is a resting motor threshold. Okay, and that it refers to the lowest intensity to elicit a muscle twitch. And in research settings, you define it as such: 50 microvolts, at least 5 to 10 trials. This is a very old kind of standard that we have used. Okay, so this is it's actually a muscle response. It's similar to a nerve conduction, but it's evoked on top of the brain. So active motor threshold is you don't always use it, but it's when the muscle is active. And later we'll show you when the muscle is active and you shock the brain, a lot of things happen. All right. And what really happens is that the motor threshold indicates how excitable the brain is. But if you want to compare how excitable the brain is between subject A and subject B, right? In subject A, the threshold is 50% of intensity, and subject B, the threshold is at 70% of intensity, right? Of course, subject B is a higher threshold, right? But in some patients, the threshold can be very high. It's not because there's something wrong with you or you know, but there are many variable factors that will determine the threshold. What are the physical factors? Okay, not so much age. Age, the threshold goes up a little bit, but common things include how excitable your brain is genetically determined. Some people, the brain is not so excitable, especially the motor cortex. Some people, the activation site may be not where it's supposed to be, and you're going to move it around and find it. Some people, the skull between the skull and the motor cortex can be a bit further away and all that. So there are many factors. Then there are of course other factors, including medication, drugs, medication, maybe even physical states like sleep, and people even see cycles or a period that changes threshold. The threshold does change a little bit every day. Okay, so motor threshold is important. Later we'll show you how to get a threshold. And why do you need to get a threshold? It's because if you want to do something further on, like a treatment or a research project or something like that, you define the intensity of that particular subject by the threshold, right? So for example, if you want to do RTMS treatment for depression, for example, right? You need to define the threshold, and you don't want the threshold, you don't want to stimulate too high blindly, and then heat up the coil, and then also very uncomfortable. The guy might shake, and you keep on activating the hand and all that. You want to be just at or below the threshold. So the threshold got many users, and you can read here. Drugs can affect the threshold. So obviously, the channels, like sodium channel and all that has got part of the reason why thresholds are different, right? And as you know, all these medications here, NMDA blockers, these also change the threshold. Okay, and later on, if you have time, we can show you what phosphines are. Phosphine threshold, so we are talking about motor threshold. There's an occipital cortex threshold called phosphines. So if you shock the occipital lobe, you close the eyes and you can see a brief flash, all right, at a certain threshold. That's called the occipital threshold, or we call it the phosphine threshold. So most thresholds are motor thresholds we talk about, but there are other types of thresholds that can use clinically or in research settings. Okay, so this shows you the threshold, kind of, moves slightly up with age. It's quite a frequently cited paper. Okay, nobody's going to redo this experiment. Okay, it's time consuming, but this is the gold standard of what threshold would be like. Would over as you age. Okay, right. Okay, now I just want to show you the direction of coil. Okay, for non-directional, non-focal type of coil, like the round coil, interestingly, if you want to activate the right side of the brain, right, the right cortex, your coil current, later on you'll see the coil current will be flowing backwards. And you flip it over the other side, you activate the other side, right? Whereas for the focal coil, then you need to activate on the motor strip, as close as possible to the motor strip. For the leg area, interestingly, I wouldn't try very hard to use the 8-shaped figure of 8 coil because the activation is quite difficult. The leg area, as you know from the homunculus, is very deep. So you can use the round coil, a slightly bigger round coil, and move it a bit anteriorly, like 2 to 3 centimeters anteriorly, and you can find activating the leg. But same principle, anti-clockwise on the right and then clockwise on the left, vice versa, you can try. So interestingly, this is how the machine turned out to be, and same for the hand. So the hand, like I said, you can try on the motor strip itself using the focal coil. You can also use this one. But in the leg, you move it a bit front, and then you get the twitch, and I showed you earlier on. So you move it a bit more to the front, and then you try and activate the leg. Okay, so we'll show that later. Just keep in mind. Okay, now this is very important. Okay, but interestingly, the muscle twitch, at least for the motor response, is quite interesting. If you have fairly low threshold, okay, so these machines usually go up to about 2 Teslas. If you have fairly low threshold, or like between maybe 40-50% of 2 Tesla, which is about 0.8 Tesla intensity, and you can sometimes you can even turn up to 70-80, and in a relaxed muscle state you can have a small muscle twitch like that, MEP. But if you contract the muscle, or we call it facilitate the muscle, you go up like 5 times or even higher, and in the MEP will be a lot bigger. The latency, or we call it the cortex muscle latency, doesn't change very much actually, but the amplitude changes a lot. And this is called facilitation. I'll just go to tell you why. Okay, so the other thing is that the amplitude is not very reproducible. It changes, goes up, down with each successive stimulation. Okay, you can try to control it, but often, and if you put it at low intensity, sometimes the variability is more. And of course, it's individual. Not much clinical utility, but this is related to the probability of firing of the motor neuron, the cerebral motor neuron. You can see using this method called PSTH, and that is how we are. So what I'm trying to say is that as we talk, as we do our things, we listen to lecture, whatever, the thresholds actually keep changing, and the pool of motor neurons that are activated is changing every second, every few milliseconds. And every time we shock the brain, you get a kind of variability. So to reduce the variability, you try to make measurements that are less variable, and that is the latency, or what we call it. I want to show you the central motor conduction time. And the amplitude itself not so great. Okay, right. And then the other thing is that because the motor cortex has got inhibitory and excitatory neurons, they actually act together, and when you shock shock the brain and record the EMG, you can get the MEP here, but it is followed by something called a silent period. Okay, later we'll show you what it is. Interestingly, this silent period is a period where it suppresses the response, and it must be something that is activated, which is inhibitory, some form of inhibitory circuit at the same place where you shock it. So TMS not only brings in a positive kind of motor response, but it also has an inhibition as when the muscle is activated. And often when you do TMS, you don't see this because you must put the sweep to a much longer kind of sweep. Then you can see that this follows. Because most of the time you put the shorter sweep, then you see this thing, which is this thing. You don't see the silent period. Okay. So silent period is actually a surrogate marker of cortical inhibition. Okay. Okay. Now, very important. This will imply the patient, the implication to the patient. Will show you something called the central motor conduction time. Okay. In my opinion, after doing so many single shot TMS over the last 20 years, this is the most robust measurement that you have. And the central motor conduction time is for cervical cord disorders. And why do we call it central motor conduction time? It is actually a cortex to anterior one cell conduction time. Okay, so those shocks that we have are coming about 20 milliseconds from the head to the hand muscle is cortex to muscle latency. Right, then you can subtract it from what we call it the peripheral motor conduction time, which you can obtain by shocking the neck, which I will show you later on. You're shocking the neck, you stimulate the neck muscle, the root, or about the same way, you can use the F wave, divided by 2 and subtract it off. You get roughly the same normal value, which is upper limb about 7.7 milliseconds, and lower limb 16 milliseconds. Okay, don't forget, this is not cortex to brainstem or whatever. It's a cortex to anterior one cell conduction time. Okay, so if it's prolonged, you can say that there is central motor conduction time delay. You can say there's cortical spinal dysfunction at or above the anterior one cell. You cannot say exactly which level it is. Okay, at or above. You cannot say. So you ask the question if there's something in the brainstem or some stroke or that. Then you got to say that you're not sure, because sometimes you have a big stroke, you have cervical myelopathy, so you have a double lesion. Then you got to remember that it both can actually delay the central motor conduction time, right? And for the lower limb recording central motor conduction, it's about 16, so it's about double. So it kind of tells you that we are quite proportional, right? So from here to the C8 muscle, we are about half the distance from here to the chordae equina, right? So 7.7 times 2, about 16 milliseconds. So that's quite consistent. So this is how fast it travels. So this probably all the myelinated fibers, and roughly the calculation is about there, similar to nerve conduction. Okay, so TMS can excite the cortex. Actually, if you do something like imagining or reading or talking as you stimulate, you can find that the MEP can become very big, but it's variable. So hence the error bar, right? The error bar. Okay. And of course, I showed you that it can inhibit the cortex. And this inhibition can be enduring. It can outlast the duration of the stimulation by a little bit. So if you deliver one shot, it can be enduring, at least to the extent of the silent period, right? And then if you deliver a train in RTMS, it can actually be even more enduring, right? So in treatment of depression, you do it every day, you give 2,000 shots, Monday to Friday, you do it for a month, right? The effect kind of adds on, and it might last for another month or 2, then you come back again. So that's treatment to RTMS. So the effects can be enduring. Enduring means it outlasts the time of stimulation, right? It's enduring, right? This is just to remind you that when you shock the brain, don't forget the pathway. Okay, it reaches past the subcortical areas, brainstem, then there is the anterior one cell. It makes one connection here. It makes one synapse here. Hopefully one, maybe one, can't be a lot. if you record from the small muscles of the hands and feet. If you record from other muscles, I'm not sure. Okay? So, as accurately as possible as you would like to stimulate the cortical spinal tract, you are probably activating other tracts as well. Okay, so the MEP that we have from the small hand muscle, a lot of people don't know this. This is largely, I will use the word large, not entirely. This is largely cortical spinal tract. Because people don't understand that our body is built in such a way that as we sit down or erect on our chair or we shift our posture, the axial muscles and the proximal muscles, neck muscles as well, are not fully cortical spinal. There are other tracts coming down, I'll show you in a while. Okay, and these are not directly activated using the coils that we have, but some of it contaminated. Okay, so you got to understand that part. Okay, so this tells you that if it is purely cortical spinal, the longest fibers, right, come down, do one crossing at the pyramids, and then it comes to one synapse, okay, in the pure state. And then you get these findings that I showed you. Okay, show you. So this is tells you that you can shock the brain as well, you can also activate the other cranial nerves as well. So these, you must be careful because some of these round coils especially is not very focal. Okay, another depiction of peripheral motor conduction time, right, where you are. So the response is here, and then the subtract this off, and then you get the central motor conduction time. Right, so this means shocking the neck and activating the root. So where does it activate in the neck? In the root here. It activates the exit of the foramina, just slightly up of the exit of the foramina. You can also stimulate the root using electrical stimulation, but it's very painful because, again, I told you, because our body is non-conductor. But if you use the magnetic coil, it is very elegant. But the problem is, you don't know where exactly it is. So people do experiments to find out where it actually activates. Later we will show you, when you activate the root, actually it's very constant because there is a lowest threshold around the exit where the root turns out. And that is the point where the magnetic flux will stimulate the root. Okay, so there are some, you need to know a bit of that as well. Okay, this is the same thing. Peripheral motor latency and all that. Okay, this slide shows you what I mean earlier on. Right? Most of the time, in the pure situation, we are activating the spinal tract. But don't forget, there are a lot of these tracts that are coming down. Okay, and they are not as crossed. So how much is the cortical spinal tract crossed? Most of the time, 85%, right? 85% crossed, 15% comes down ipsilaterally, and we always ignore all this. Okay, but with electrophysiology, you can show that these tracts can be upregulated. But a lot of these other tracts, right, including the reticular spinal tract, vestibular spinal tract, these maintain posture. They actually innervate the axial muscles, the neck, the proximal muscles, including sometimes the deltoid, the biceps. You don't get a nice big MEP like those that you the small muscles of the hand. So you can try it later on. The MEP is not small because most of the time they are actually uncrossed, maybe half crossed, half of them are crossed, half not crossed, and then they actually are not directly stimulated using the coils that we have done. So you need to understand what are the limitations. Okay, so this is just another diagram to show that. Right. Okay. So where are we actually stimulating? I don't really like this diagram, but this diagram is exaggerated to tell you there is arrangement. Okay, but you must remember that this arrangement is not the same in everybody. Right? Yours and your neighbor is not the same. Right? Some are more on front, some on the back, some are bigger, some are smaller. Maybe you speculate you're a piano player, the representation of the fingers may be bigger, maybe, don't know. Right? Can you show it with TMS? Maybe. Right? But one thing for sure is that the knee or the leg or the foot, which we record, is unfortunately very, very deep inside. So you need a round coil to activate it. Okay, so the H-shaped coil, you have a bit of a problem because they're only activating this portion in the motor strip. Okay, what about anterior to the motor strip and posterior motor strip? I don't think these coils are so accurate not to not to as well. So some of the premotor area, which may also supply neurons to, say, some of the more proximal muscles, axial muscles, reticular spinal tract, vestibular spinal tract, may also be activated. You can contaminate the response. But don't forget, you are actually trying to isolate the response by recording, not from all this, you're recording from the small muscles hand. That is as pure as cortical spinal as you can get in the human body. Unless you're built differently, it should be that way. Okay, so just what I said for this area, you put the coil, you're trying to isolate this part here, but behind, there are connections coming forward and then backward and then supplementary motor area. And in fact, some of the vestibular spinal tracts are around here, maybe even be further front. It depends on all of us. It depends on who you are. Different. It's very different. Okay, so this I mentioned already. Okay, mentioned. Okay, how do you measure the silent period? Okay, so a silent period maybe about 70-80 milliseconds, sometimes as long as 120 milliseconds in length. We measure it from the point where the EMG is suppressed. Some people measure a silent period from here to here, but I prefer to measure it from here to here. And because it can be variable, we want to average a few and get an average response, or at least get the shortest response. Something like an F wave, right, or whatever. And you can actually look at the silent period following this. Okay, so cortical silent period, very difficult to get in other places, but they have been recorded in facial muscles and all that, in some patients. But in most subjects, the best success is in small muscles of the hand, right? Try to don't be a cheat by activating the EMGs very little. Try and activate it. Make the subject push all the way, right? Either by opening the hand or pushing upwards, and also use as high as intensity as possible until the silent period doesn't change. If you cheat by using a low intensity, you may not really get a silent period or a very reproducible silent period. Okay, clinical utility of silent period, we'll talk about this later. Okay, so mechanism, probably inhibition, GABA. GABA has been implicated. They use experiments directly show that GABA is correlated with silent period, the GABA mechanism. You can actually get silent period on the ipsilateral side as well. That means let me show it to you. So this is ipsilateral. That means instead of stimulating the right side and recording on the left side, you actually stimulate the right side and record on the left side. And this is a reflection of the transcallosal conduction time. So it is delayed in some situations like demyelination or in clinical practice we don't really use this, but just to tell you that silent period can be activated on the ipsilateral side of the activating muscle as well. It can be recorded bilaterally as well, by the way. You have two channels, EMG, you can look at it. Okay, this is an experiment to show that we can actually look at even the threshold of activating this ipsilateral silent period. So anything you can measure threshold. And this shows you the coil direction in activating the silent period. Is it where should it be posterior, anterior, posterior? There are different people with slightly different direction. So what does this reflect? It reflects how you're wired in your brain, how your inhibition and facilitative neurons are interrelated, and not everybody is the same. Okay, this I went through. Okay. So root stimulation for central motor conduction time. Either you can use the F wave or you can use the root stimulation. Root stimulation is simple. You use the round coil, put it over the small muscle hand, C7, C8. So C8 or the T1 root here, you activate and get a root response. No need to facilitate. This is a peripheral stimulation, all over the L5, S1. So later we can try that. Alright? Okay. Now for focal coils, there's something called motor mapping. Okay? And later we can show you using the, this morning we tried it, it does work with the 8-shaped coil here, the figure 8 coil, quite nice. Most importantly, you must locate the center of gravity. And then you must draw a grip or use a cap and map it. So first you find the what you call the optimal position or center of gravity. So what you do is you go to the most likely area, which is for the left hand, the right vertex 4 centimeters to the right, and then 1 or 2 centimeters anteriorly, and look for that spot. If this is the spot that gives you the largest motor twitch, then that is the spot, and move it around there. Okay, then this one, if this is the spot, then you construct a grid around this spot, right? And the grid should be 1 centimeters apart. No point making it smaller. Alright, 1 centimeter is already very generous because I don't think these coils are so focal as to go below 1 centimeter. And you can actually map this motor representation of the small muscle of the hand or any other muscle. But I told you for the reason the small muscle of the hand is the best because it is physiologically it is wired as to fit nicely into the cortical spinal tract activation. So mapping can be used nowadays with neural navigation for pre-surgical planning for brain tumors in conjunction with functional MRI and all that. Some hospitals use that. I don't use that very much with my neurosurgeons. So this is one example. So if this is the optimal point, right? You construct a grid around it. You can make it bigger. It can be 9 or it can be more, but no point too much because over the periphery you cannot get a muscle twitch, right? So best twitch here, 1 centimeter here, 1 centimeter below. And this is how you get to it. This is an experiment that we did a long time ago. We actually, this patient over periods of several weeks, we actually looked at the map size changes. So they actually become bigger and bigger and bigger. And then over the period of motor training, and these numbers basically show you how big they are in millivolts. This is just one example. You can come up with your own example of what it is. And this is another software that can show you the change in the map size. This is a paper that we published some time ago on how the map size changes after cervical cord surgery, cervical spine surgery. So before, in normal people it's quite small, the representation. Then you have myelopathy, it becomes bigger and bigger. Then 3 months after surgery, it kind of normalizes a bit. But this is another way of looking at it. You can look at these bar charts. Pre-surgery, and then after surgery, the map size comes back again. So this is using motor mapping and normalized to the MEP millivolts. This is recording from the small muscle of the hand. I won't try it with other muscles. It's difficult because it's contaminated by other tracks, but this is one paper that's published quite a while ago. Okay, so to summarize, later on we'll show these thresholds. That's all threshold. Secondly, the central conduction time, variability of MEP, silent period, a bit of mapping, ipsilateral silent period, or we call it transversal conduction time. We won't have time to show these paired stimulation or train stimulation, or we call it RTMS today. Okay, this one we can show later on peripheral magnetic stimulation, and one we can also show if there's time how to activate the facial nerve. Maybe later on we can show if there's time activate the facial nerve over the base of the skull. You can activate it around the exit of the facial nerve at the stylomastoid foramen, and you can actually activate the other areas, including not only the nerve root but also the plexus, lumbar and brachial plexus. Alright, because of the property of magnetic stimulation. The big problem with Erb's point activation or lumbar plexus activation or the groin area is not the pain. It's that you don't know where you're activating. Okay? So you don't know where to draw, and then you can't measure conduction velocity because you don't know where you're activating. But you can show that this can be done. Okay? So facial nerve activation, be careful because very short latency. You can be contaminated by volume conduction, blinking, and other reflexes in the face. But we can show it to you. It's a lot less less painful than literally electrical stimulation for some people. Okay. So this is actually one use, and actually we actually did a paper long time ago on activating 4 areas and making a recording on the nasalis muscle. If you have time, you can show this nasalis muscle on the face. You can stimulate the brain. You can actually do the brainstem stimulation. Not sure whether this coil can activate the brainstem. If you have time, you can try. You need a bigger cone, double cone coil. And then of course the stylomastoid foramen, and then also preauricular on the face. So 4 areas you can. Actually preauricular, it's best to use a normal electrical stimulation. Okay. So recording is auricular, ocular. This is one way we demonstrate that we can actually activate the facial nerve close to the brainstem, the facial motor nucleus. So a lot of people say that, oh, I think you are actually activating the post-auricular region. Okay, and then you can also do the tongue. Okay. This shows you that it's a bit different. The brainstem, actually, the response is different. It's a lot. The latency is longer than the stylomastoid foramen. And then, of course, on the face itself, you can actually use nerve conduction. You can use normal electrical stimulation. So facial MEP from the cortex is quite small. And same for cortical bulbar as well. You can use it on the tongue, like I show you the picture. You can make a recording on the tongue. I don't have the gadget here today, but there are tongue clips that you can clip on the tongue and get a twitch. And again, the 4 areas, all right, cortex, brainstem, the spinal skull. Okay, maybe for the genioglossus or the tongue, a bit more difficult for this area to record. Okay, so okay, this paper was published more than 10 years ago. Shows you all the responses here. Okay, quite nice. If you have time, you'll try to activate that. Okay, same thing. Yeah. So this is a patient that had some kind of central demyelination, and then we showed this. Okay. Right. Okay, the second part of the talk, we're going to talk about the utility of this method. Okay, apart from RTMS, which now has been FDA approved for treatment in depression, migraine, and latest OCD, obsessive compulsive neurosis. These are FDA approved, okay, for the device. And for single shot TMS, I think the most useful is for central promoter production time in cervical myelopathy. Okay, you know very well that in Asians, our canal, cervical canal is very narrow for whatever reason, genetics or whatever, and often the narrower canal predisposed to myelopathy. Okay, and we're talking about spondylotic myelopathy. So we know that a lot of this myelopathy actually encroaches onto the cortical spinal tract and into palp tracts. So that's the reason why SSEPs have never been very sensitive. Right, I'm sure you've seen patients do SSEP, bad myelopathy, SSEP normal. Even, you record from the leg, much longer tract. So you need to find some way to look at the anterior tract, right? Anterior pathway, right? Okay. So not so much as actually determine the direct level of compression, but more the prolonged central motor or very, very prolonged, increased kind of central motor conduction time. And recently it has been shown that they are correlated with a lot of things, physiologically, including the AP diameters, flattening of the cord and MRI, and then lots of things. So a lot of research on this stuff. So we were one of the first ones to put a large series on this, and we continue to use it every day. In fact, we have like 5 to 10 every day. This period. The rest of the TMS users are more research-based, but this one you have it every day. And as you know, I told you earlier on, the motor mapping, it can show dynamic changes before and after surgery. Actually, it is something quite real. It's shown in functional MRI as well. So if you have a chronic myelopathy, quite interestingly, the motor map changes. Very strange. So there is there's a retrograde kind of change in the plasticity of the motor cortex in spinal cord disorders, spinal cord demyelination, compression, even tumors, and trauma. Okay, so this is quite well known. And CMCT has been used to screen as well, screen for. And this method of calculating CMCT actually corrects for the peripheral motor conduction time that is seen with radiculopathy, which may occur in addition to myelopathy in many patients. Okay, so let us remember that. So this is cervical myelopathy, different forms. This is radiculopathy. This is herniated disc causing radiculopathy, and this is basically central canal stenosis, and then maybe myelopathy. So sometimes you see the MRI doesn't show very much, but you're not sure. Sometimes it shows compression, but it doesn't affect the cortical spinal tract. I'll show you some examples in a while. Okay, this is from a paper published a long time ago, in 2008, and it shows you 4 different classical scenarios. Fairly normal kind of cervical spine, with just a little bit of disc, not really touching the cord. Type 2, touching the cord, but not compressing it. So I call it less than 20%. Right? Now we know that the AP diameter actually figures in this, right? And then this one shows compression. And then the last one is severe compression with a signal change inside the cord. I can't show very much. I usually have a dot here. So these are the 4 scenarios. Right? So this is the worst scenario, right? So in the first one you get quite a nice MEP, reproducible. The second one delayed, the third one hardly seen, fourth one absent. So what actually happens is, perhaps, I don't know what really happens, because this is not nerve conduction, but perhaps there's some desynchronization of the descending bodies, cortical spinal body, that come down, which result in a very dispersed kind of synchronized MEP, and also delayed latency here. So this is normal subject, and this is a patient with a myelopathy compression at a single level. So this is the figurative depiction of it. Something like this. Not sure, we don't exactly know what happens, but it's very sensitive. So you can even differentiate this, and later on when we do MRI, we find that actually this patient has fairly small compression, not that much, but there is delayed central conduction, CMCT. Okay, so CMCT. These are the papers you're interested in, all very old papers, but they're a very large series, a few hundred patients. It shows very high sensitivity for even mild compression, and it's well correlated with MRI. So in our hospital, they tend to send patients for screening before MRI. So some of the patients, they get MRI for lumbar spine, and they think that, oh, I have neck pain and all that, older patients. And they say, okay, well, instead of MRIing the whole spine, we send you for TMS and then see if there's anything. TMS is normal, they can just watch the patient and do some physical therapy or some symptomatic treatment. Okay. Yeah, so this shows you that MEPs can be obtained for other muscles, including pec major, and actually they can be delayed. So pec major has cortical spinal tract. Cortical spinal tract, this is an old paper of mine. And then this paper tells you that the upper limb, the FDI, first dorsal CMCT, it can be independently used as a predictor for good outcome in cervical decompression surgery. So if it's delayed, we tend to recommend that the patient go for surgery. But I think this kind of paper you should be careful. It gives the surgeon an additional need to tell the patient you should go for surgery. But ultimately, when you do cervical decompression, what is the main thing? You are actually buying insurance for the patient, right? You're buying insurance to ensure that for the next 10 years or so, the cord will not be compressed by further, because you're opening up the stenosis, the cervical stenosis, and keeping it open. And in the event that if there is a twist or traffic accident to the neck, then you are buying insurance that you won't further injure the cervical cord. That is what is the main thing. All these things about prediction, yes, it is late, you have a good reason to go for surgery in fairly early, but most important, you are buying insurance for the time to come. Okay, if the patient has cervical myelopathy, already has changes in the cord, doing the surgery is not going to help. It will not make the recovery of the cord symptoms better. So you have a patient that comes in with already some bladder bowel problem, walking spastic, all that. By doing the surgery, it basically prevents further injury, but you should tell the patient that you may not actually cure the myelopathy symptoms any faster. Okay, so this is just to show you that the use on that. Okay, so this is what they do. They cut open here, right? Cut open and then they free up the spinal cord. But there are foreign bodies last time they used titanium plates, sometimes they use bone graft. Nowadays there are more, there are other types of joints, elastic joint, implants and all that they use. So eventually it's still about keeping the space open, right? So when we demonstrate CMCT, we are talking about that. So again, just to revise, the office utility of TMS in cervical spondylotic myelopathy. What is that? What are we talking about? So, before surgery, surgeons come here and they want a baseline documentation of cortical spinal dysfunction. So, okay, CMCT delayed by 5 milliseconds, something like that. They want that. That's one possible use. Another possible use is unsure MRI. The type 2 and type 3 one. You're not sure, the compression is a bit dead and all that. MRI is in front of you, but you want to see if the cortical spinal tract is damaged. It doesn't look at other tracts well, but at least the cortical spinal tract, so they ask for that. Another possible use is post-operative documentation of cortical spinal dysfunction. So many of these patients, they come here and they are not walking well, they have a lot of pain, but they say, oh sir, 5 years, 10 years ago, I have had a cervical spine surgery. It's not better. I went to see my orthopedic doctor and I did an MRI and there is spinal cord injury, old injury, that. So why is not better? So surgeons say, oh, that's there, the decompression is done, the canal is wide open, but you want to document your cortical spinal injury. So they send for this. So this is one possible use. Then earlier on I said screening for cervical myelopathy. So some patients come in with a bit of neck pain, and then they say, oh, hand numb, weak, and all that, very non-specific. Some of them have migraine, even I've seen cases. Migraine, weakness, numb, all sorts of things, neurology, right? Then they come and say, okay, come and do a TMS. It keeps us very busy, screening for cervical myelopathy. Put it in inverted commas, screening, okay? Localization, okay, can you localize? Very difficult, I told you. It can actually tell you the delay from C1, the C8T1 root, or anterior one all the way up, but it can't exactly tell you, is it C7 or C6 or C5, because as I told you, if you put it in other muscles, they are not necessarily cortical spinal. So I would be careful about localization of to that level of region. Okay. Differential diagnosis. Why differential diagnosis? So that CMCT can be delayed. Later on, I'll show you in many conditions, right? So sometimes you show that CMCT is abnormal. You need to go back to the original person who referred the case to you and ask whether is it the spinal cord or something else on top of it, alright? Because sometimes after doing MRI, I say, oh, the MRI looks normal, but your CMCT is delayed. What causes the delay? Then later part of the lecture, we'll talk about that. Okay, then the other things like cortical mapping, but most important, cost benefit. One of these sets of coils and machine costs about $100,000. Okay, are you going to invest $100,000 if you're like private hospital, right? You have the investor. You buy it in a government hospital, I can invest $100,000 for this kind of utilization. Okay. Or perhaps you can build in some research use. You know, if you're in a university or academic institution, you can build in some research use and some service. Okay, that kind of justifies the expenditure for 100,000, maybe, perhaps. Okay, so all this comes to my mind. All right. So, okay, motor neuron disease. Okay, is there a clinical utility for motor neuron for TMS in motor neuron disease? I'm really have a lot of reservations because CMCT alone is about only 10 to 20% sensitive. So, for example, you know the LS criteria. You have motor neuron disease, you have history, you scan the patient, it's quite okay. You know, no stroke or anything else. You do the nerve conduction EMG, and it suggests to you it is motor neuron disease, right? So you want to see if there is upper motor component, right? So one way is to wait for the upper motor signs to develop over time. But some people argue that TMS can do it, but unfortunately I think it's not very sensitive about 10-20% of the time, any real time. If you do it much later, maybe you can have a slightly higher sensitivity for that upper motor part, but apart from that, not really. But in research, there's a lot of research going on. So like people have looked at silent period and also trying to differentiate it using recording from the neck, above the neck, or even other TMS related methods like triple stimulation. But where do I use it in the office setting for ALS? I used it in my own patients who I think may give additional information for upper motor involvement, but I find that it's only about 20% sensitive. And it is not surprising, right? It's exons die, right? Exons die doesn't mean that the central conduction is delayed. So you ask yourself, what about MEP? Is amplitude? Okay, amplitude unfortunately is very variable. So the intrinsic variability reduces the sensitivity of the MEP amplitude. Dementia also talked about, in general, it reduces threshold. So in demented patients, the brain is a lot more excitable as a large group, right? So these are some of the more recent studies I summarized, like the multi-center study, and they actually tried to use various TMS parameters, which I have no time to go through today. Intracortical facilitation and short interval cortical inhibition, SICI, ICF measurements to help differentiate Alzheimer's disease from controls. But if you look carefully, what they're using is a complex parameter. That means they're using a scoring, clinical, TMS, imaging, and whatever. And then from that scoring, you retrospectively review the result and see how sensitive it is. It's not awfully sensitive, but it introduces a lot of parameters. Once you have a complex parameter, you include a lot of things. The more things you include, the more chances for inaccuracy. So you must be very careful. So most of these studies are using index or combination parameters, using various parameters. And so nowadays, you know that in Alzheimer's disease, or that you need more data. In the research setting, you will need imaging and maybe perhaps even some kind of biochemical changes. So TMS itself is not enough. So what about other neurodegenerative diseases, SCA or MSA? I find MSA a lot better. Actually, in patients with MSA, I find the central conduction time delay to be a lot more sensitive than even ALS or motor neuron disease. Actually, quite interesting. And can it really differentiate different types of SCA? I don't know. I doubt so. But it can help to say that cortical spinal tract involvement is there in neurodegenerative disease. Okay. Combined lesion. What I mean by combined lesion, this involves combining the TMS that we have with the brainstem stimulation using this kind of cord. I'm not sure whether this one can do it, but we can try if we have time. It is similar to what we did. We stimulate the brainstem and subtract the central conduction time, which is cortex to T1 conduction time from this. So if the patient has something above the T1, then this will be taken care of. So let's say this patient here has got a stroke and a cervical myelopathy below, right? Then you can actually look at this. But then again, you need controls. You need normal controls. That's the thing. This basically shows you that you can stimulate, this type of coil can stimulate the brainstem and get an MEP, but then you need normal controls. Whereas the central motor conduction time that we have, the 7.7 and 16 millisecond, that control is very well established in many studies. Okay, MS. Okay, in some centers, MS centers, they have used follow-up TMS longitudinal measurements to correlate with scoring, MS scoring. Okay, and some studies even say that it can predict the EDSS scorings. Okay, but what is the clinical utility? I'm not sure. I think for MS clinical is important, quality of life is very important. So psychosocial status is very important. This is a small addition to what we have that is known about MS. In the research setting, well, it gives information on maybe eventually using it to select some kind of treatment strategy or rehab strategy, but we are not there yet because the data is still not very, very clear. Parkinson's disease, most studies show threshold not change, and there may be discordant findings as well. Some say high, some say low. A lot of these movement disorders, they're not sure, and even the silent period, some say it's shortened. It may be followed, it may be prolonged by medications, and it also changes with an on and off period. Again, I won't use it in the clinical setting or not in even hospital or in the private sector, private practice. Not sure how to use it. So in the research setting for movement disorders, dystonia, lots of studies on this. RTMS for dystonia started from these studies which actually demonstrate that the excitability has changed, actually. And from that on, they justify using RTMS for small clinical trials on treating Parkinson's disease, gait disorders, and movement disorders. Epilepsy, it's a big talk on whether it's safe in patients with seizures, right? People have tried to use thresholds and TMS parameters to be a diagnostic biomarker in epilepsy. So far, not much success, right? And the utility in actually looking at the physiology of as a change of cortical excitability, rather than just a single biomarker of whether the patient is epileptic. I think we're very far away from that. Migraine, FDA approved for double shock for treatment of migraine, but lots of studies on TMS. But all the studies, as you can see, this is even my own paper. Shows that it's conflicting on excitability because migraine is essentially a time over time fluctuating complex, and it's also variable, location centric, and depends on the phase of the migraine, even menstrual cycle. So migraine without aura, perhaps silent period may be shortened. Migraine with aura, depending on which phase of the person is in, there may be increased excitability. So with phosphine thresholds, you have time, we will show that later. We can demonstrate that on. Stroke, a lot on RTMS, but essentially what it shows is that there's a lot of interesting information that's been shown, but essentially you have stroke affecting the right hand, that means the left cortex. What happens is that the right cortex is hyperexcitable. And this hyperexcitability crosses the corpus callosum and inhibits the other cortex. So it actually makes the paretic hand a lot worse. So TMS has shown this, and people have tried to use RTMS to suppress the other cortex, right? Using slow frequency RTMS. No conclusion, not right at the moment. There's no success, no FDA approval on the horizon. It may take a long time. Okay, and then functional disorders. What am I talking about? Functional disorders. Okay, functional disorders is not in function, but actually disorders that are psychological, right? So sometimes it does have a little bit of utility, but the limitation is that, as you know, the method that we're using is largely cortical spinal. I've said many times. It only looks at cortical spinal integrity. Increase in MEP duration has been, voluntary contraction has been followed in stroke controls, and these are like very, very soft kind of use in paralytic patients. And motor imagery, we'll show later, can also be used in these patients. But the positive changes that you have are not by self-diagnostic. You still have to go back to the clinical and psychosocial aspects of these patients with so-called functional disorders. So this kind of gives you a little bit of information, a little bit more information. And lots of research applications we won't use today, but largely mapping disruption of cognitive tasks by inhibiting a particular area, training, changes with drugs, new drugs, especially new drugs that are on development, how much it changes, sometimes in whether they have seizures as well. New epileptic drugs, they tried using this. So this is a summary of the simple summary of the changes. This paper just came out. I'm not sure whether it is on. I think it is on. Maybe it's on. I'm not sure whether it's on open access. Actually, I'm one of the co-authors. This gives you clinical, mostly focusing on clinical diagnostic utility of TMS in disorders. It gives you first part. It tells you about the principles, some of the parameters, a bit complex, but it summarizes the latest data. And the second part summarizes a little bit of what I went through just now on the disorders that we use TMS. But if you ask me very frankly, cervical myopathy, CMCT is the most robust and most useful. Whether you want to pay the $100,000, I'm not sure. It depends on your investment, right? And all that. Okay. The last bits I want to talk about safety. Okay. RTMS, there are quite a few papers on RTMS affecting seizures. There's also even RTMS in patients with seizures on paper. And even in RTMS, actually it is shown to be safe. So single pulse TMS is extremely safe. Alright? I've probably done like more than 10,000 of these. I've not seen, touch wood, today I've not seen a single seizure on the table or anything. Okay, so it doesn't really, the effect is very, very transient, and most important, you must build into your system to check all this and make sure there's no pacemakers. But if you ask me, if the patient tells me he has epilepsy, am I going to do CMCT on the patient? No, I say no, because it is a risk-benefit calculation, right? So what you show that the CMCT is changed, right? And then the patient has epilepsy. Why we have a fit? Okay, the patient is unlikely to have a seizure when you're doing the TMS, even if it's epilepsy. But 2 weeks down the road, he comes back and tells you, hey, doctor, after your TMS, my seizure frequency has increased. Now you're in trouble, right? So I do not do TMS on patients with history of seizures. Okay, this is very important. All these gadgets, you have to be sure. You have to check. You check, your technicians check because once you spoil one of these, then you're in big trouble. Alright? It's like the MRI thing. You miss it and you go to the MRI, then you're in trouble. Okay? Apart from that, there are no kindling or historical changes that are shown to date. Okay? So single pulse TMS is approved only for research in the US. So in the US, they do not have the kind of CMCT kind of service office utility, but ironically, they have RTMS for depression, headache, and OCD. Okay, there are many international guidelines on RTMS, particularly. Single shot is not a problem. On RTMS, that tells you whether you should be using a certain frequency with a certain power duration over a certain period of time. In fact, you ask our vendors from Neurosoft, they will be able to give you information on what is the safety guideline. And they're often built into the system. So it's unlikely that during treatment you will exceed any of this. Right? So there are many guidelines for RTMS, so not to worry. So it's actually a very safe procedure. Okay? It's safe, it's painless, and it's quite effective. For single shot TMS, again, I told you cost versus benefit versus safety. Right? To start using the TMS, you need to read up and understand the physiology of the machine interface with the brain physiological properties itself. You need to understand what is cortical spinal function and what are the other descending tracts that you may environmentally stimulate. And also understand what is the muscle twitch MEP characteristics, some of these, how it is derived and what it represents in the clinical setting. There are obviously a lot of widespread diagnostic and research applications, but not everything is very, very useful. Often you need to corroborate with other investigative modalities, including blood tests, imaging, even nowadays neurogenetics, right? Genetic screening. And some limitations include the method itself. People don't understand the method. The activation, particularly peripherally, not sure where the site of activation is. The findings are dichotomous because the brain is very variable. It can facilitate or inhibit at a short period of time. And some of the findings are, is it really primary problem or is it a compensatory result? So there are many new techniques coming out on the horizon to simulate the brain, right? Including not only RTMS but other types of methods, TVCS, TPCS, and many different methods. And they each have their own advantages and disadvantages. We have to be aware of non-invasive brain stimulation is a developing field, but again, cost, benefits, safety must be borne in mind at all times. Okay, this book of mine that I published about 10 years ago needs a revision. Later on, after the break, you can have hands-on, but now we'll just maybe go for a toilet break. Later on, we'll demonstrate these including the coil you can play around with, MEP, thresholds, mapping, root stimulation, for speed. We do that in a while. Okay, I think that's about it. We finished the lecture, just over an hour. Right, we'll take a 5-minute break at the toilet while we set up the demonstration now on the normal person, and I think Neurosoft has arranged something for us. And maybe you film or you can come forward or whatever way that we can do it.
Excuse me, do the demonstration of normal subject.
Normal subject first.
After that,
we'll take a short break. A short 5-minute break. We have to set up this thing.
Do you have any questions? Because the Professor Law talked about 2 sections. First, the principle of RTMS, and secondly, he introduced the new diagnostic tool of RTMS, not therapeutic use. Because now, when RTMS are available in Vietnam for a few months, or half a year, the majority of patients are depressive patient or Parkinson or neuropathic pain. So that this is the therapeutic tool for treatment for patient. But now the Dr. Law present a new field of diagnostic. Very, very interesting.
Okay, I don't mind, I'm sorry I don't have time for the RTMS, but you can also ask in Vietnamese, ask questions in Vietnamese,
Okay.
and then you can translate, you are uncomfortable in English.
Bây giờ các bạn có muốn hỏi câu hỏi gì có câu hỏi đặt cho liền đi. Em.
Yes, Professor, I would like to ask you to highlight some of some situation that the TMS is superior to other diagnostic tools, because throughout your lecture, it's my impression that the TMS is not a very sensitive tool.
Yeah, very good question. It is not really superior to other methods, but it is complementary to other methods. So the best one I told you is cervical myelopathy, cervical spine, right? Just go back. So there are situations like this. So like this, you know, I don't know, sorry, let's find the right one. Where you have a cervical spine, a cervical cord compression, just about this. Just about this. Often they come in with this, and they will ask us to do a TMS to see if the cortical spinal tract is affected. So you'll be surprised. If you ask me whether in this particular patient the CMCT will be abnormal, I don't know. You'll be surprised. It can be abnormal or it can be normal. Because sometimes the cortical spinal tract is not, you know, you've seen the spots. You go into surgery, you see the cervical cord is very small. Very small. I think it's even smaller than, it's a bit smaller than my thumb. And these lesions here can compress the cord but miss the cortical spinal tract. It may not be right there. But it may be there also, you know, you don't know. So they want that information. And TMS can screen that out. You can screen that out, okay? Of course, you will have a situation where you have a situation where you have a very severe compression, right? Just move back, sorry. You have this kind of situation, right? What I call it like pancake, right? Then you say to yourself, why are they referring this patient for TMS? Right? But they still want it. Because they say that, okay, maybe I want to operate on the patient, but I want to first show the patient that the cord is already bad. So after surgery, if it doesn't get better, well, too bad. You know, your damage is already there. You know, you see TMS already showed this kind of MEP, you know, that kind of thing. So that kind of thing. So like I said, the clinical utility, the office utility is largely not in ALS, not in motor neuron disease, or not in Parkinson's disease for single shot TMS. You can try that for treatment, but for single shot TMS, by and large, this is the situation where you want to use the method, right? As summarized in this slide here, office utility TMS. So if you ask me, this is the main one. It's complementary and to imaging and clinical. The other methods I don't think is superior at all. Okay, for diagnostic purposes.
Thank you, Professor.
Any comment?
In Vietnamese is okay. We can translate.
Mấy bạn cứ hỏi đi. Em tên gì hả? Em tên gì? Không, em một rồi mới hỏi em tên gì?
Dạ, em tên Mười.
Mười.
My. Dạ.
Bệnh nhân nào?
Dạ, em chưa có đi làm.
Chưa đi làm.
Dạ.
Tốt, nhiệt tình là tốt. Nên tập trung vào cái tổn thương gì, ví dụ cái giới hạn, ông nói rõ thì giới hạn chẩn đoán thì chúng tôi là khảo sát được cái rối loạn chức năng của bỏ corticospinal nó bỏ sống tôi, chứ không thể nào xác định rõ được cái tổn thương. Nhưng mà nó hỗ trợ chẩn đoán.
Yes, I would like to ask how to determine the motor response when the patient they have the myelitis. Yes, because the motor response of the myelitis may be higher than actuals of this patient.
You're talking about the threshold, right?
Yes.
Yeah, so yes, so good question. The threshold, it may not be threshold. So in patients with very severe myelopathy, I think that's what you mean, right? You're going to have this situation here. Absent. So later on, you have a subject that's coming and he has myelopathy. And I don't know him, but it could be very severe. You might end up like that. There's no response, absent response. Or it may be a very delayed response, okay, or very small response. So this is upper limb and this is lower limb. Right? It could be a very small response that is delayed and the central conduction time will be delayed. CMCT will be delayed. This is normal. So if you get no response, you can't measure central conduction time. Is that what you mean?
But if this patient they have the depression, yes, and we use TMS for indication of depression and how to
Depression.
Yes, and we can determine the motor response. So how we
threshold.
can so how we can set up the protocol for the patients, or maybe we have the limitations of the motor response. It means that SSA for the woman, maybe we use the 50s intensities like that. I mean like that, yes.
What I suggest is that if you are trying to determine the threshold for RTMS for depression treatment, you can try other muscles. Okay, you can try other, because you know better. You can try other muscles. You can try maybe the EDC, EI or EDC, and look for the threshold. Because if this kind of situation, if you have this very severe type, you're gonna have this. You're not gonna get anything. You can do that. Otherwise, you have to refer to your protocol. It may be so high that you cannot stimulate 100%. Right? You can do a calibrated, maybe a reduced one, maybe half of it, 70, 60, right? Unfortunately, the protocols are defined by 5% below the active resting motor the active motor threshold, and it's going to be difficult. So you should not stop the treatment just because the patient has myelopathy. You have to come up with a lower stimulation threshold. It is, I would say that's for depression, it's more like the number of pulses that you deliver that give you the clinical outcome. And more than the how high it is. If it's certain, from my experience, even if it's very, very high, you don't enough pulses, your effect is not going to be that great. Is that what you mean? I'm not sure. You have to find you can't find the method, you got to find the next best method.
Em vừa mới hỏi
Dạ, ở đây học y dược.
em tên gì?
Dạ, Trang.
Trang. Bây giờ này cái motor threshold đó là em thử bằng cái giống như là evoked potential. Excuse me in Vietnamese. Excuse me in Vietnamese.
Yeah, Vietnamese. You translate for me.
Okay. Tức là for motor threshold, you put just like evoked potential and you search for the response of an adductor polycyst. Said like if the weight cuts, the response of the thumbs around 50% of normal, and for depression, because this is just like apathy of the patient and very inertia, no response, and you have to increase around 120% of the lowest motor response. You understand? So that if you stimulate by motor evoked potential, and you see that picture, and you see that when the most weakness, you can see first very strong, but after that very weak. You choose that just like 50%, and you increase more to treat depression. it's not the same as the Parkinson.
Ý nghĩ các bệnh nhân có tổn thương tủy này nên cái
Anh nói chiều về trầm cảm, còn cái tổn thương tủy tôi không biết. Tổn thương tủy thì là cái mới mà bây giờ ông nói là ông vừa rồi nói cái này nó chỉ có lợi ích từ trong chẩn đoán thôi, chứ không phải lấy ở cái đúng không? Và nó sensitive hơn somatosensory evoked potential. Tự nhiên thế gọi là cảm giác nó nét hơn, chứ ông nói là chỉ là một phát bổ sung thôi, chứ cái này ông nói là điều chỉnh. Tất cả cái phần sau của ông là ông nói được bài chẩn đoán bổ sung cho cái chính xác hơn. Ví dụ như là những bài chẩn đoán dementia, hay là frontotemporal hay chẩn đoán ASNA, hay là mấy cái tổn thương, và đặc biệt là trong tủy là cái này nó bổ sung rất nhiều. Okay.
Yeah, what is can you translate?
Okay, it's a little bit you present a topic very interesting about the complementary tool for diagnosis of many diseases.
Yeah, but a lot of the diagnosis is on.
I know.
Yeah, not very.
Complementary.
Yeah, it's not useful in office setting. More complementary. But for cervical myelopathy, I think it's helpful. It's very good. Yeah.
Okay. Excuse me, I have one question.
Yep.
I see in some slide you show that you have the coil you put in the back of the head and you say it's a stimulate brainstem. So I heard that in stroke we have the patient with dysphagia. Okay, you mean maybe the problem in the brainstem. So how we know that coil truly stimulate the brainstem and what the useful tool for?
Okay, the one in the coil. Right?
Yeah.
Okay, I don't know whether this coil can do it. But the method is invented by Dr. Ogawa. Dr. Ogawa is here, you can ask him. But we've tried it, and in some coils it works. Okay, what it does is that it activates a descending volley that probably cortical spinal tract. They showed it. Alright. But if there's a stroke in the brainstem, then common sense will tell you that it's unlikely to get any response. Right? So is that what you mean? I don't know what you're asking. Right? So you're trying to say that if there is a stroke and you don't know, right, will you get a response? In fact, I tried that method. Okay, not everyone can get it. Right? It's because the brains, okay, it's got a lot to do with physiology. It's not an easy method to activate. I would say that out of every 10 subjects, maybe 5 or 6 I can get a nice. Okay, we can try that later, but it's a bit painful because it jerks the neck. Not everybody can get it. The reason why is that when you stimulate the top, when you facilitate the muscle, you are actually getting a loop. You're getting a loop is a kind of a loop, and it facilitates. Right? But here, the facilitation is not so robust for sure. You don't have that kind of interneurons that facilitate. So the response is smaller, and also the brainstem is quite deep, inside. You have to be very accurate. Here, you can roughly get, I told you the spatial resolution with the figure 8 coil or the round coil. It's not so high, but here you have to be quite precise. So it's not so easy. You see, you can get it. Some patients you can get it, some patients can't get it. But in some, Dr. Ogawa has described it, this method, you can use it.
Excuse me, you asked a question about dysphagia. Okay, you are a neurologist. I know well that all of the deglutition from brainstem is inert by both sides. So that if you know so much you omniculus còn hình con người nhỏ trên não thì chúng ta thấy là cái vùng mà hầu họng nó gần cái vùng cánh tay mình. Cho nên tôi dùng cái để trên cái M1 này gần đó mà mình chỉnh đi vẫn làm được như thường.
Nói là ví dụ như cái vùng nuốt nó nằm ở cái tổn thương thân não chứ không phải ở vỏ não này, thì nó sẽ kích thích ở vùng M1, đúng không thầy? Cái ý thầy nói là vậy, kích thích M1.
Nhưng xuống cái kia và hai là bao giờ hai bên both side of the left side and right side will connected by corpus callosum. That means when you treat TMS for tinnitus, you Don't treat only the head, vùng thính giác á, vùng thính giác ở vùng left temporal parietal region. Head, you cannot treat only the head. You have to. The first session we treat the head with the high frequent, just like 10 heads. But 10 session after, you can treat the DLPS dorsolateral control region on the contralateral to treat the tinnitus. Just like that, when we treat the dysphagia, you can treat, theoretically, you can treat the opposite side of the delusion, but you can treat the M1, but near the omniculus for the pharyngeal, oropharyngeal. That's
Ý em là trong cái rối loạn nuốt nó có cái chức năng của tiểu não tham gia trong cái vấn đề đó nữa.
Tiểu não không được em chứ phải là tiểu não và brain stem nó đi xuống, còn tiểu não là thành phần với lại những cái như là MSA, không phải là của cái nút.
Tại ý em thấy cái slide của ông là ông kích thích brainstem, thì em không biết cái cách nào để họ đưa được cái vô brainstem.
For stimulation the brainstem, you should use navigation, and the next session on Saturday, the neuroscope will present the navigation for the cerebellum, because you have many patients with MSA, multiple system atrophy. You have to access the cerebellum for imbalance and.
Okay. So I think you're talking about whether we can stimulate the brainstem, yeah? But you want to stimulate the brainstem for any reason? Or is it just for research? Or it depends on what you want it for. Right? We can try and do it also. It's not easy to get. I'm telling you that. Even with that one, that round, the one, it's not so easy. Some patients you can have it because the facilitation is not very good on this part. Even if you ask the patient to facilitate with contraction, it's not that nice. It's small. Any other questions?
Please. No more question.
You want to? Okay, so it's no other question. We can try on a normal subject. So we really thank Neurosoft for volunteering. And Andre is here. He's got good threshold. I tried it on him today. Lowish threshold, not very high threshold to talk about. And we'll demonstrate on him. Thank you. First and foremost, thank you so much for accommodating. Wait, let me go to that page. So the height of the can be as low as 4 to 5 millibars, or can be very high. Sometimes 10 millibars. So your gain should not be too much, but you can adjust it along the way.
И учим мужчины точно. One channel on a good policies brevis, we check impedance, it's perfect.
Okay, so the impedance perfect, and where is the point maximum stimulation? So draw a line on the intraoral line, and then find the vertex. It should be 4 centimeters lateral and 1 to 2 centimeters anterior. But in some people it is posterior. Alright? Point here, and orientation is usually 45 degrees to the anterior line. 45 degrees. If you go and you do mapping, angle, you find that 45 is correct. And this is using the focal coil. The lazy way is to use the round coil. Later we'll show you the round coil. Okay. Okay, the round coil, the stimulation is on the side. This one is on the middle. Alright, again, it's not so focal, but it's more focal than the round coil. Alright. So you put it here. Here, and then what's the 50? You start at 50. Okay, now it's at rest, at rest. So you see whether there is a resting motor threshold. Okay, you already got the threshold, so you can put it below 45. Yeah, 45. So low threshold. Okay, can you put it at the definition 50 microvolts? Okay. So that means 0.05. 50 microvolts. 50 microvolts. So in experiments, they use 50 microvolts, 5 out of 10 trials. Okay, 1. Okay, no. Okay. Yeah, got it. So it's 5 out of 10. Wow, it's very good. So I think you're going to 40.
Chưa đăng ký đi học, đăng ký đi học. Để coi thử.
Okay, this is about it. Some are absent, some are present. So your threshold, resting motor threshold is about 45. 5 out of 10 trials. Okay, so if you want to do RTMS on him, like you say, this is so you might want to calibrate it at just below 45, maybe 2% or whatever. But it's very low. Those are very low motor threshold. Right? So some people are very low, but it depends on many factors: the coil, the hair, the scalp, age, medications, and all that. Okay. So now we go to something comfortable. Let's say put now it's 45, right? 40, right? 40. Okay, put 45. Okay, now at rest. Okay, nice MEP, right? Okay, if you facilitate, facilitate. Okay, now I'm facilitating. See how big it is? Yeah, again. Okay, try one more time. So you don't facilitate, right? Okay, now you facilitate. Facilitate. No, facilitate. Facilitate means contracting the muscle. Should be a lot larger. Is it a big 5%? I think the game is small. The game is small. Facilitate. Don't contract. Don't contract, you don't get anything. Not contract. Yeah, see, once you contract, it goes up. If you don't contract, you can hardly get very much. Sometimes there is. So your threshold is about 5%, very low. Very low. But it's normal, about 40 to, most people are about 40 to 80, maybe about 40 to 80. So you're about 45% total threshold. Okay, so that's the active motor threshold. Okay, this is a resting motor threshold. You can also do the active motor threshold, but once you contract, it's a lot more variable. So I suggest the resting motor threshold. So when do you do active motor threshold? So like for example, you ask the question, patient has cervical myopathy, right? You may need to do active motor threshold if you want to look at the motor threshold. But the problem is, most studies have in RTMS for depression calibrated to the resting motor threshold. So it really depends on your comfort level and your what you are used to using in your setup. So that's usually the case. That's what happens. Okay, so this is threshold. Anybody any questions about threshold? Okay, so it's important to know threshold because like she highlighted one example, it gives you a standard intensity to stimulate. Okay. Not so much as for diagnosis. Okay. Now the second we'll demonstrate to you is the MEP central motor conduction time. We'll do the central motor conduction time followed by the central motor conduction time. Okay, we'll use the instead of the F-wave method, we'll use the root stimulation method. Okay. But don't forget this coil is a bit curved, so bear with me. Okay, so central motor conduction time, we already got the peripheral motor conduction time, right? That comes at 20 milliseconds. Right? Okay, try one more time. Okay, increase to 50. Just double check.
Can have you guys?
55. Facility. Okay, see, facility is bigger. Facility one more time. So you see, it's a lot bigger, but the latency doesn't change that much, but the amplitude kind of increases. Just get one. So the latency, the amplitude doesn't change very much. The amplitude changes, shape changes, but the latency doesn't change. So we are at how many milliseconds? Oh, 82 milliseconds. 18 milliseconds. Okay, so about that, you can move the cursor to the okay. Now we will demonstrate the neck stimulation to subtract central motor conduction time. Right? So because this coil is a bit curved, I have to do it this way. And where am I stimulating? So this is C7. This is C7, right? Actually, I use a round coil, but I'll try and see if I can use this one first. C7, and then here's a C7 just below there, the T1 here. This is a small muscle head T1. See if I can get what we call the peripheral, the nerve root response. Yeah, try with this. What's the intensity? Here we go. Change the coil. Change to the round coil. So why is it a bit difficult for this one? Because the round coil will activate the nerve root. I show you the diagram. Maybe I'll show you the diagram. It actually activates the root and it comes out in turn. So this TMS cell magnetic part is quite interesting in that it always captures the lowest threshold on activation in the peripheral, not the central, in the peripheral nervous system. Same for stimulating the leg as well. The lumbar root. So okay, we use the round coil. So the round coil, the point of activation is on the side, not the middle, on the side. Okay, go to the next channel. Okay, just test it. So this road then you should be this side. So when you the middle there's no magnetic flux. So you put it if you put it on here to stimulate this side. What happens is that this part just sits right on top of the motor area. And you try this side and it sits right on top of the motor area. So what you do is that you put it at the vertex, move left, anterior, posterior, lateral, medial. Here's how you do it. When you apply it on the tangential on the scalp. Later on you can try. So it sits very nicely on the top. So there is a cardinal difference between activating the nerve root and the brain. There are differences. And of course the cranial nerve. Okay, we can try the root first. Okay, there's no need to activate. There's no activation. Just direct this. Again higher. There you have it. You can see it there. Right? So what you can do is that you can actually turn it this side and see if you can have a better response. It doesn't change much. See, interestingly, you see the latency doesn't change much. You go to the next one. Increase the gain. No, not the stimulation. That's the gain, the size. The gain. Okay, just one more. Sorry. Put it at 60. I think good. Yeah, it's very strong. It's same thing. So you put the cursor there and you subtract. Comes at about. You're gonna put the cursor. Yeah, so your cerebral conduction time is quite little. 700. Marker is. Yeah. Okay. So how many?
Duration 6. 7.
What's the first one? 13. So 13 minus which was 18. 5 milliseconds. Central conduction time. Usually about up to 7.7. So about 5 milliseconds from here to the cell. So that's central conduction time using the nerve root stimulation method. So let's say if you have cervical myelopathy, what happens? Right? First of all, the peripheral motor production time may not change very much, but the central motor response, the cortex muscle latency will be increased. So that when you subtract this, you get a very prolonged central conduction time. So, or sometimes you might even have nothing, no response. It is a severe cervical stenosis. Okay, now since you have this coil on, let me show you how to stimulate using this coil on the left hand. So when you're stimulating on the left hand, like I can see you've got to put it on the vertex. But you've got to put the coil, the current got to run this way, run backwards. So that the induced current in the brain is anterior forward. Okay, so for the right hand group, use so this one I'm going to call it, the coil will be this side, B side on the vertex. Okay, with the leg, we want to do the leg, activate the leg, right? And then we're going to put it more anteriorly, right? So you can move it around here, a little bit to the right, a little bit to the left, a little bit to the right, a little bit to the left. Let's see whether we can get this one. How many are we? Okay, now at rest, whether we can get it. Okay, 60. Yeah, got it again. Okay, now you facilitate. Okay, now it's just contracting the muscle. Oh, it's much bigger. How much bigger is it? Huge. Right? Don't facilitate. Very small. Once you facilitate, it's like maybe 8 times, 10 times. Once you facilitate, much bigger. Okay, so this is another method of using it. If you want to use the leg, you want to do the leg, but dirty. You're wearing socks. You can show the leg. The leg, very difficult for low threshold person like him. You might be able to get it at rest. Okay, maybe Dr. Lee. You can try the leg, don't mind. Right? You try at rest. Okay, the leg will come at 40 milliseconds. 40 milliseconds. So if this one comes at 20, this one comes at 20, this one comes at 40, right? Because double the distance. So at 40 milliseconds, you're going to use first one square is 8 milliseconds. So you'll come out the fourth square. Fourth square, fourth width. And the MEP is a lot smaller. Okay, maybe half the size of the hand. Okay, so why half smaller? Why a lot smaller? I tell you the honest truth, not activating all the cortical spinal neurons. We're only activating as much as we can activate. Okay, same thing. Left leg at rest with the coil on the head, but more anterior. Okay, more anterior for the leg. If I can get. Because sometimes leg in some people you can't get it, but at rest. Okay, not much. What's the sweep? What's the 5? No, go to 8. 8 milliseconds will be no, but 10 also can. 10 is okay. 10 is fine. 10 is okay. 10 is okay. You'll come out the force. Okay, we try that one. Okay. Okay. Okay, nothing much. 10 is okay. No, 10.
Let's try maybe the ambulate.
Yeah, I will ambulate. Yeah. Okay, later you I tell you what, you ambulate first. Okay, got something on. Alright, got something there. It turns up to 80. It's not 80. Okay, got something. Okay, so now you facilitate. Okay, press down. Actually, for leg facilitation, I tell you honestly, I like someone to put the hand there, put the finger there. But you activate the other side.
Yes.
But we can try something close. I like to press it there. And you activate now. Whoa, so much bigger. So much bigger. So it's oh god, it's about same thing. So for him it's easy, low threshold. And even for legs, correspondingly low threshold. So that's okay. Next bits will show you. So central motor conduction is same. You will stimulate the back, the spine, the lower back. You want to do it, okay, we can do it this way. Okay, this is number 5. Number 5. Okay, go lower, so 70. Yeah. Number 5. Go. Be short. That's the. We should come at about. Okay, what is it? Okay, I'll turn the coil and see the other side.
Let's try it without facilitation.
Try it. Did they have it? Yeah,
See, doesn't change response.
The response, but it doesn't change very much latency. Yeah. It doesn't change very much. So again, it searches for the lowest point in the nerve. So for some strange reason. So there's another way of subtracting, but yeah, I think we don't do too much about it. Okay, then we can do the maybe the cortical silent period. So cortical silent period is during activation. I normally ask the patient to try and activate as much as possible. Although people tell you, oh, 20% is enough, not really. Try and activate as much as possible, using all the strength, and give it a bit of rest, and then do the next round. So cortical silent period, not easy to obtain from the other muscles. Usually the hand muscle is the muscle. And it's about maybe 50 or maybe 17 seconds in duration. Sometimes longer, sometimes high, very high. And if you increase the intensity, you can actually increase a little bit. Yeah, I won't use it. I won't strive to use cortical silent period for diagnostic purposes. Okay, let's use it. You can use this also. Okay, so okay, there you go. See the up here. Okay, next, increase intensity. Okay, 80 here. See, when you increase intensity, the sub here increases a little bit in duration. Okay, next one. Okay, a bit more. See, still increases a little bit. But you reach the maximum, you won't go to 0. You won't go to 100 or whatever. Okay, let me come out. So you see how beautiful it increases the intensity. So I try to facilitate maximum intensity. You go to 100, about there, you can't go beyond 100, right? It's too Tesla machine. You can't go beyond 100. So when you measure the cortical silent period, you have to measure from the point where the it's the cursor. Where would you measure? Probably there. Yeah, and then the first point is so some people don't like to measure from the point. Okay, where's the first point? First, the beginning of the silent period. Yeah. No, back. No, back.
What? Not sure.
Left to the left. Shift it to the left.
The beginning is
So the beginning.
stimulation point.
Yeah, the beginning. Some people use the measure. So the offset point is quite clear, but the beginning point, again, because the EMG curve goes up. So some people use the start of include the MEP duration inside, but I often measure it at the point in front. Yeah, there you go. Yeah, there. Yeah, first point. Yes. Yeah, and you use that one. That one, right? You use that one as the first point, and then the second one is the and the second one is the end. Second point is the one where the EMP restarts again. So this is cortical silent period. Interestingly, it comes after the MEP. So people argue, what is this thing? Right? Is it what is it? It's actually a loop where the potential goes through the infiltrate in the neuron, right? The neuron, whether it's people say what basket cells, islet cells, basket cells. Cell type not sure, but correlation is with GABA mechanism. GABA. So that's cortical silent period. Okay, we'll show you the motor imagery. Motor imagery. I'll show you what is motor imagery. So you can have this one is more fun, but I wouldn't say you can use it in patients who have psychogenic or functional weakness. But in some experiments, they use it to look at motor control. So motor imagery is that when you have MEP or certain side at rest, you don't move it, you mention the movement, right? So it's called movement imagery, right? And in rehab, movement imagery is actually a rehabilitation strategy where you don't move it, but you practice on your own. Okay, say you're free and then you do nothing, then you practice the movement imagery. It's supposed to change cortical blood system, but using a single stimulation, you can actually show that the motor response is somehow much a lot larger, even without movement. So that's movement imagery. That's why it's called imagery. I mentioned, right? It's mentioned. So imagery. So if okay, I just show go to a new go back there. Yeah, show it. Yeah, cool. Yeah. Okay, we'll try. Okay, you imagine movement now. Imagine your finger is coming up. I'm giving him extra cues, like encouraging him. Okay, all the way. And then goes. So it shows you that the motor program is actually active. It's an active thing. It's a real thing. Moving contact in real time. So this is motor. I'm coming quite late. Okay, now I will show you the. We'll show you the phosphine threshold. You want to try? Later on you can try. So I'll show you what's phosphine threshold. I think we'll change the problem. Okay, phosphine threshold is. I think this one. Phosphine threshold last bit. Later on we can try on one or two. Because we take a 5 minute 10-minute break, we have the patient. It's supposed to end at 5. So the phosphine threshold is a threshold where you stimulate auditory cortex, close the eye, you see a flash, very fast, maybe 30 milliseconds. I can't be 30 milliseconds. It might be like 200 milliseconds. Because 30 milliseconds, you don't have enough time to process. But what you see is that you see a brief flash of light, and actually you can map it. Alright, you move it a bit to the right, you might get on the right, you move it a bit to the left. And people have used it to study migraine threshold. And that is the migraine with aura patients have been shown to have lower threshold of phosphines in comparison to people with no migraine aura. Or even patients with no visual aura. So phosphine threshold, unfortunately, he can always tell you that he sees it, but don't know whether it's laughing. Alright, but I just show you what it is. It's a very big flash. Later you can try on yourself. If you're okay, none of you have epilepsy, you can try on yourself. So what we do is we put this coil right? This is and then it's angled over the occipital cortex. Right? We put it about 60. Yeah, 60. We'll try that. Close the eyes. There's no motor response. Okay, only half the people can see it, by the way. Normal people, how about them can see it? Got it? So it sees a flash. So about 70 is phosphine threshold. So like a bit like an aura that you see. Okay, so, okay, thank you, Andrew, and really appreciate your pay. Sorry. Okay, I thought we'll take a short break. Should we take a short break?
Yeah.
Last break. Can we come back?
What's wrong with the
10 minutes. We have a patient.
Yes, we have 2 patients.
We have 2 patients.
Yes.
thanks to Dr.
Yeah.
For bringing the patient. So we come back in 4:15 and we'll get ready the patient and we'll demonstrate central conduction time on the patient. Later, can you give me a history, description?
Yes. Cô này là có tiền sử, không có tiền sử co giật, cũng như không có tiền sử nhịp tim. Là cô này là từ 4 tháng trước rồi.
Dạ 4 tháng trước là cô có một cái tai nạn giao thông ở vùng cổ, đột nhập của vùng cổ. MRI của cô là có biểu hiện là đột nhập vùng cổ sống cổ, ảnh hưởng đến vùng tủy cổ từ C3 đến C6. Sau khi tổn thương tại vùng tủy cổ thì cô yếu tứ chi. Sau khi tập phục hồi chức năng cỡ 3 tháng nay thì là có cải thiện về cơ lực và không có triệu chứng về đường tiểu. Hiện tại thì cô có các triệu chứng của nơ hoạt trên và dấu đầu skin phải. Và sau khi bị chấn thương ở vùng cái cổ thì cô này không có trải qua phẫu thuật.
I've examined her. She has wrist finger jerks. She has very wrist finger jerks, right? She's weakness. She has increased tone. Walking, she has a mild scissoring gait. Later we'll show you the second patient. Reflexes are very brisk. And she has an extensor barbacy on the right side. Right? As far as I know, she does not have any control problem in the urine. So, at least for this kind of patient, you should have a very brief history. She does not have seizure. She has no heart problem. She has no pacemaker implantation. Okay, I will use the round coil to see if I can get an MEP on the left side. I will not waste time on the resting one. I will ask her to facilitate. Maybe.
Excuse me.
Yeah. From the accident, right?
So that we can show exactly accurate diagnosis by optical stimulation.
You can only show delay. You can only show delay.
I see.
From the anterior horn cell and above.
But you can identify more accurately.
Okay, if you want to identify more accurately, you need to use the other coil. And look at subtract the cortex to the anterior horn cell. That means the cortex to brainstem conduction time. You know, the one Dr. Ugawa's method. We've used that before, but thank you. That one is the patient already has a brainstem problem already, so I'm not sure whether I can get it.
Evoked potential.
Once they are evoked potential, I don't know whether you will be helpful. Okay, so we use this one first. So left hand, again using the B side, right? B side. And how do you try to facilitate? You ask her to try and she's weak, so you ask her to push his hand. Open. So facilitate the open the other way. So I may not get any MEP, I'm just warning first. Push it. Very good. Push. Yes. Push. Yeah, a bit of. How many are we? 50? 30, okay, 40. You know MEP? Okay, 40. Okay, more. Very good. 50? 60, sorry. Oh, there's an MEP. Okay, 70. is 80. Okay, look at that. So how many milliseconds is it? How many milliseconds is it? Can't see. 20.8. It's normal, huh? It's normal. Okay, so sometimes the central conduction time may be normal. Okay, it either miss the cortical spinal lesion, alright, or it's not sensitive enough, it doesn't pick up enough. Okay, now for the peripheral motor conduction time, we stimulate the neck. Can you tell what that we stimulate the neck? Beautiful. So 20.8 minus 12.8. So that gives 8. 8, right? So the central conduction time is 8, so just above 7. So slightly prolonged. So not so severe actually. And if you want to see the size of the MEP, if you look at the first trace, the first side of the MEP, actually not so bad. It's about, how high is it? 1, 2, 3, 4. A bit small. The size of the MEP is a bit small. So I would say that she has some small MEP. Usually we use 3.5 for our patients, Singapore patients. 3.5 millimeters is the lowest level. This one is about 1.9. And the central conduction is just above normal. So subtracting. So this is a delayed central conduction. So not so bad actually. But if you were to do the leg, you might find it more. Because don't forget the leg is a lot longer. But this patient, unlike the other patient, doesn't really have that much walking problem. Later we see the other patient has got a lot more difficulty walking. Okay, so the central conduction time delay in this patient. Okay, so you see normal and Andre, and you see the normal. Yeah. Okay, okay, I think can. Okay, we try the other patient now. Okay, let's try the other patient. We're going to do a leg. Leg. Okay, okay, we can try the leg. Okay, we'll put this on the. You want to try the leg? Okay, the leg we have to use this coil. Okay, and don't go rest. Do the facilitation. Yeah, I'm gonna try the leg. Okay, so. Okay, we'll put here. You see, it's very painless on this thing. It's not. You imagine if the electrical shock would be very painful. There's heat. You should put it at about 1 square about 8 or 10 milliseconds per square. And the amplitude is about 1 millivolt. Or even half. Yeah, 1 zoom. Okay, let's see if we can measure the central conduction time per leg. Okay, normal is about 16 milliseconds. Okay, double of 7. Okay, you don't mind. Okay, answer the question now. Okay, we start at 16. Okay, we'll show.
Cái mic của ông thầy á. Cái mic đang không của ông thầy gọi đâu.
Dạ, lấy
Lấy trong đó.
dạ, tụi em không có thu mic.
Okay, I have to find the position because everyone is
Không
different.
phải là bên của bên mình à?
Của bên mình.
70.
Giờ không ông trả lại ra.
Okay.
Đeo lại trong được không?
Không có thu được giọng nhưng mà
Không, thì ông nói để cho dễ là nghe.
dạ không, nó là cái mic của chương trình, mic của
Maybe there's something there. Okay, 18.
Còn cái kia thầy nói nó thu vào bên này.
Okay, again. Very small. Increase the gain to 0.5. Very low. Very severe. Okay, try this way. Okay, one more time. Very small. Okay, one more time. After facilitate, push, yeah. Ah, yeah, beautiful. Okay, there you have it. So it comes at how many milliseconds? 44. 43. Yeah. That's not so bad, you know. 43 is not so bad. But if you do the okay, that's the why we do the explanation. Right. Okay. Okay, turn it down to 70, 60. Okay, feel. Okay, there you have it. One more time. Higher. Okay, can. Okay, beautiful. So, 43.3 minus. Move back. Back. No, back. The other way. Yeah, okay, that's it. 43.3 minus 21.4. How much is that? .3 minus 21.4. 23.4. 19.9. 44.3 minus 23.4. 19.9. Still prolonged. It's normally 16. Divided by 18. Prolonged by 3 milliseconds. So she has prolonged central motor conduction time from the upper lip and the lower lip. Yeah, I won't recommend any other muscle. Yeah, so 18. Normally it's about 16. Okay. So okay, thank you. Okay, we've done that one. Okay. We try the second patient. Very nice. Thank you very much. Very much.
How about the outcome?
Outcome. No value. But it will help the surgeon to show that after operation, that this man, he had MRI, he had surgery, but it's not getting better after some months. It will show that it's not getting better because the original injury is still there. He will tell you that. Okay, he's a similar patient. If you see the gait is very unsteady. Initially, he had a problem with urinary control. He had is it a road traffic accident? Can you give the history? Describe it. Yeah.
Bệnh nhân nam có tiền sử là tai nạn giao thông là 5 tháng trước ở vùng trong tỉnh chấn thương vùng cột sống cổ, thì cái vùng mà bị ảnh hưởng sau khi chụp MRI đó là và sao là phẫu phần C5/6 thì bệnh nhân có được phẫu thuật nẹp viết vùng cột sống cổ. Thì hiện tại thì bệnh nhân là có triệu chứng tăng trương lực cơ yếu cả hai chân hai tay, và yếu chân phải nhiều hơn bên trái, tay phản xạ trong xương trước gì. Bệnh nhân có triệu chứng cảm giác là tê hai bàn tay và vùng chân.
So I noticed that he has a cervical collar. He has a surgical scar here. Right in the center, right paramedian scar. He has a if you examine him also, you notice that his tone is increased in the wrist. And then he has quite the wrist finger jerk. He's weak, He's weak. He can't extend it very well. It's quite weak, right? And his reflexes are very brisk. You tap it, it's a wrist finger jerk, right? Similar this side, there are some features as well. Okay, see the finger jerk? See? It's not an inverted supinator by the wrist finger jerk. And we do the volume curve. See that the thumb crosses across, right? And then you in wrist, and then Berminski, very severe lesions. The ones that the cases that come to SGH in Singapore, they are not as severe as this. They are the type that have like, you know, they're very well, there's a bit of neck pain, and then they have an MRI that shows that maybe there's a bit of compression, not sure, and the patient keeps insisting there's something wrong, and then the surgeon will send people to us. Usually we do this and then they will go back and explain to them, you know, the conduction is normal or whatever. Okay, we do exactly the same thing as the other patient. Okay, we use the same. So I think it's a little bit more severe. Maybe. Yeah, instead I can't see the first dorsal and dorsal very well, so I'll try my luck on the ABB. I don't know whether the ABB is small. If the peripheral muscle response is in the upper limb less than 5, you've got to be very careful. You might not get a very accurate MEP. If the lower limb, same thing, the lower limb, if the MEP is, if the Cmax is below 2 millivolts, you must be careful. You might not be able to get a response. Okay. So if you have severe peripheral neuropathy or motor neuropathy or something like that, very small motor response, don't bother to try TMS. Don't bother. Alright, okay, we'll try that. Same thing. Okay, I explained to him that we are going to do a. This is a magnet, it's not electric. Okay, we'll do the same. Okay, so I use a round coil on the B side. So B side on the vertex, and then move it slightly to the right. Okay, because this coil is a bit small, so it moves slightly to the right. Angle tangentially. Okay, so this time the facilitation is up. Okay. Okay, come to 50. Not much. Okay, 60. Actually, for the facilitation, you can put the sound, the EMG sound, but this one I don't think it's a sound card. So you can put the sound. You can hear the facilitation. Okay, come in. Is there a speaker? No speaker at all. No speaker at all. It's not important. Okay, try that. Okay, there's a EMG. Okay. Now. Sure. The impedance okay. Okay, it's activating. Okay. Okay, we try again. No, okay, 7. Okay, we'll try again. Okay. No, don't. I think his response is very small. So you ask him to. Still push up. Okay. sorry about delaying, but anyway, in the meantime, you might be wondering why we're doing this. So imagine that if he had not gone for surgery, right? He has gone for surgery 3 to 4 months ago. If he had not gone for surgery, then the philosophy is slightly different from what we're doing now, right? And I can tell you, many patients, they've gone for surgery and they come with this. Then, but if you have not gone for surgery, it gives you it gives the surgeon a bit of insurance that, oh, it's abnormal already, you need surgery, right? Then do the surgery, then you see you look for the best. Then you can explain that, okay, there's already spinal cord injury. But you have not gone for surgery. You've gone for surgery and then you come back and say that not better. Then it's a bit different. Then the patient can say that, okay, you have demonstrated that my test is abnormal. Why don't you send it for the test before? So it's a slightly different philosophy, right? And then you want to ask yourself, is there any point in following up the patient? It's not very useful. The improvement is not in tandem with the change. In other words, the method somehow doesn't, the CMCD doesn't really quite correlate with follow-ups. So it's good for diagnostic, particularly before surgery. But after surgery, there's a little bit of value in it. But if you want to follow up, I won't recommend it. The abnormality is going to stay for a long time.
Nói chung là trong vòng 20 kg hay là cấp cứu mà sao nói trong bài ở 5 tháng.
In the meantime, while we're doing this, there's some tricks of getting a nice response. What you do is I use alcohol swab and clean the contacts. Because in the hot weather, no aircon, then the humidity is going to affect the sweating, evaporation, and then the contacts going to mess. So you need to scrub the skin. It's the same as nerve conduction, right? Do that. Okay. And then try and get the patient to facilitate properly. Don't use a half-hearted facilitation. Get a good one. It's difficult to measure how much facilitation, how much force, but you just keep encouraging the patient. It's a bit of grounding for How many here have used TMS or at least tried TMS before? Anyone here tried? Nobody? Only one person? RTMS? Any psychiatrists here? Yeah, we can try again. You put to, okay. Okay, can you help me to facilitate this? Put to 1 millivolt. Yeah, this might be very small. Here, come. 1, 2, 3. Yeah, still interference. The ground. Wet the ground. You wet already. Sometimes it happens. So So in places like sometimes Vietnam we use put in you can actually try and add extra ground or something like that, and then put the ground very near to put the ground between the recording and the stimulation point. You can also use an extra ground on his hand. And in some situation, you can actually connect the machine to the, I think 3 years ago I went to Chore Hospital. We used the wire. I went downstairs to get the wire and we tied to the water pipe. Do you know the sink? The sink, there's a water pipe, right? We added one more wire to the water pipe and then hook it there as an extra ground and help. So in some building, you see, they use that extra trick to ground the and reduce interference in one way. Then, because I don't know what building you are in some of your building, we have interference. So you same thing, you go potential, you go to the machine, you find the ground, and then you hook the. In fact, you can actually hook the metal case of the amplifier, EMG machine. Here we're using a laptop, so you can use an EMG machine. In many places, we connect this to the EMG machine and use the EMG screen and trigger. The machine will trigger the EMG. So the EMG machine, you can put an extra ground. That's one trick. This one is more of a laptop unit. This is a no EMG, doesn't need the EMG. Yeah, we're just doing a bit of troubleshooting. This happens all the time. There's a bit of there's a cardiac ECG artifact there. So we're recording an ECG of this man. Yeah. Intermittent. Sometimes flat, sometimes there. You want to try one time with okay, there's an ECG, but never mind. Put the bar. Okay, facilitate easy. Go up higher. Increase the intensity to 70. Okay, great. Facilitate. Try again. One more time. Go back. No MEP. Push. 80. Again. Pitch. Ask her to push this way. Push this way. Okay. There's a small MEP there. Okay, 90. Okay, increase the gain. Very small MEP. Increase the gain to 1 millivolt. 90. 1 millivolt. Oh. Alright, try one more time. Yeah, you see the MEP is there. So small. Okay, and then if you want to do the central conductor, see it comes at 20. 39. How big is it? How long is it? 35. 36 milliseconds. Normally it comes at 20 milliseconds, 36 milliseconds. So you want to do the next stimulation. I'm not sure whether I should do it. This has got a metal there. 200 meter volts. Got metal. Still can do, but he doesn't mind. He can do one. So you don't mind. Yeah, okay. Turn down. We do the peripheral conductor. Yeah, but the metal might interfere a bit. So in this situation, what do we do with the metal? We use the F-wave method. We can't do the F-wave now. F-wave. We can do that.
Why not? We can.
Can you do the F-wave? We show the F-wave method. So we do the F-wave. Okay, we want because he's got a metal implant here.
Make a small piece.
Do the F-wave. So with the F-wave, F plus M minus 1 Divide by 2.
We need a little bit time to get electric stimulator.
Oh, you need electrical stimulator.
Maybe 2 minutes.
Yeah, you can halfway. Right. Otherwise, I might we just use this one.
Okay.
Yeah, because it might be difficult. Okay, we try this one, but in practice you can use the F wave if you don't like it. But okay, then that show this one. So put to 60. No need to facilitate, no need. 60 by small. 7. Please got it. Okay. Yeah. He's probably got an injury at the neck there, and with the metal. It's a metal, right?
Yes.
Yeah, so the metal is a conductor. It repulses the magnetic demonstration and it repulses the magnetic stimulation. But you can tell that it's abnormal because normally it should come on the 4th square. Right, so regardless of it, if you use the FP, I'm sure the central conduction is very abnormal. Right? Because it's coming at 36 milliseconds. It should come at 20 milliseconds. It's already off by 16 milliseconds. Okay, so I don't think we need to do that. This is a very short. And then you see the MEP is so small, 1 level.
200 microvolts.
100 microvolts.
That's
So it's a good
difficult to record.
Oh, very hard to record. But anyway, we can still get it. So this is not a normal stress, not a normal stuff. Okay, more. In fact, this one is more significant than that patient, but then again, this is more severe post-operative. Okay, we finished the patient. Well, not much time. Can we try? Anyone keen to try on each other or something like that? We can. This is no one has tried it. We can try playing with the machine here while I'm here and everyone is here. Okay, thank you very much. Thank you. Okay, we will try the. We'll try the. You can come forward and try the coil. Anyone keen?
Shoot examination is electrostimulation. It's related, by the way, we have electrostimulation.
Oh, okay.
On any case.
Stimulation. No need, because it's so small.
Yes.
Yeah, and in fact, I'm not sure if the CMAP is small. Yeah, so anyone want to try the coil? We have round coil. We even have that what we call it, the cone coil, double cone coil. If you're interested in double cone coil, you can try. Okay. Anyone want to come forward and try? Anyone has tried it before? Anybody come forward?
You can try on me. No
You
problem.
can try on him. He likes the shock.
What do you want? You want?
Okay. Yeah. I want you to check out. Yeah, and where's the rest? So, draw the line. CZ is actually 4 centimeters here. Right, so if you use the full coil, yeah, but you use a round coil, you put the coil right in the middle and back. So, a bit fun is the leg for the head. And use the B side. Okay. You can try you can try the MEP. Can we let her try the MEP? Try the MEP. Let me help you.
Обращайтесь, я всегда к вашему.
Use TMS. Think of environment. So the middle. Yeah. So CZ is here. CZ is here. CZ is here, right? So for this one, I think a little bit you can try. Yes. You send up to how many? 45. Got it? Got it, right? You send out it. Very nice. Hold the cup. Hold the cup. Hold it. You gotta hold it. Then you can do facility. Very nice. Right? So you want to try that. You can try it. But the other part is also very nice part. Very nice one. The other one is you can simulate there, or you can press here. Not a problem. You press here easier. It's very easy. Yeah. Full switch, right? You can increase it. Increase it. Yeah. Okay. Anyone else want to try? Anyone want to have a? We got some time. A little bit, couple of minutes more. Okay, B side. This way, right? So the CZ is here. And then because the ground coil a bit small, you move it a bit to the side. Hold it. Okay, short. Okay. Cervical. Okay. No problem. Okay, cervical you put it in the center, and then you move it in. So this is C7, right? So the root is around here. Yeah. Got it.
Will stimulate the root?
It's parallel root. Because the root turn, right? So it will hit the turn. You activate the muscle as well. So you get tips, but the recording is on root. This is like an EMG. It's like a Anybody else want to try?
Вы видите, когда двигательную единицу стимулировали, она у нас все стимулируется. Мы конечку стимул дали, а он пошел туда. Двигательные единицы делают нее в нижней периферической мышце. Вы в одном месте стимул дали, а он распространится. Я думаю, нет. We will get the response from the right hand also, yes.
You want to try the right hand, you go to flip to the A side. Oh, those you can, it doesn't matter, it will, because it activates the two sides. Activate both sides. But you can try, you get a little bit bigger sometimes. Sometimes you can turn the other way, you get a bit bigger, but you move it up a side.
If peripheral nerve is okay, yes?
Peripheral nerve, okay, you want to try peripheral nerve stimulation. You can short here. Try. Make your back, don't mind.
Yeah.
Make your back. The problem is that you can get a nice response. Beautiful. but you don't know where it's coming from. You don't know where. Okay, like for example, you want to, instead of stimulating, you want to stimulate here. Okay, you put like that, you put the cord flat. And lower. How many? Maybe no, okay. Enough. Oh, it's beautiful, is it? Activation is beautiful. Because if you imagine if you use the nerve spoil, a lot of us done nerve conduction, you use nerve spoil, right? That's painful, right? You try to, use the big stimulator, turn up duration, but use this one.
This is not painful, by the way. By electric stimulation.
Electric stimulation is more painful. Yeah, more painful. Beautiful activate. In fact, you can activate facial muscles and all that, just that you don't know where the stimulation point is. So brachial plexus is actually very good. It's actually very good. I sometimes I use it but you need to do a side-to-side comparison, and you need to have normal controls. You need to have controls. Normal values. Anyone else want to try? Or you can try each other. Oh, wait. You want to try the double cone, right? You want to try the double cone? The double cone? You want a double cone? Okay. To the end of the day, we will try just for interest, we'll try the double cone. Okay, I have not done a double cone for a long time, since my study, published. I never use it, but since Dr. Gawa is here, we'll try a double cone. Okay, the double cone, you can see the intersection. I'm not sure, but the double cone is in the middle. The stimulation point is not the side. Presumably somewhere in the middle. So we place it right at the back here, depending on the head. Some people have bigger heads, some people have small heads. It will stimulate brainstem which is about 1-2 centimeters deeper under the skull. So it's supposed to. So you need to calibrate it, move it a bit deeper, and you did a first slight facilitation. Okay, where should it come? So if it comes here, it becomes about 20 milliseconds, right? It becomes about 20 milliseconds. So Andrew has a bit long hand, so maybe 25 milliseconds. Then it will come maybe about maybe just under 20 milliseconds or 15 to 20 milliseconds. So it's still the same thing.
If I put it in the CZ, so it was times.
Okay. We put on CZ. What do you use? It was when it was first developed. It was first developed for leg stimulation. But I prefer the double cone coil. I prefer the round coil for leg stimulation. Yeah, you can actually get the leg MEP, but it was subsequently adapted to here. So this one you need to put like that. Okay, a bit. Okay, you put the CZ. Okay, where's CZ? Sorry, not CZ. It's the inel. See the inel. Okay, you put like that. Okay, then you press this one. Okay, the gain cannot be. Okay, the gain is alright. Okay, go. The gain will be higher. 1 millivolt. Okay, now I let you push again. Persistent. Oh, you got it already. Okay, one more. Turn up a bit. Oh no, MEP. MEMG. Turn up to higher, a little bit higher. Maybe 60. Yeah, try this one. Turn up, down. Not sure. Hey, that's it. There you got it. Okay, one more time.
Facial muscles. Teeth construction.
Turn up to. But too late, right? How many milliseconds? Should come between 15 to 20 milliseconds. Too late. Seems to be 75. Oh, you got it. 75.
75.
See there. Second one. Oh, you got it. Yeah. So it's this one. The second one there. This one. Yeah. This one. So it's about Yeah, it's not easy to get. So it's a single descending body that is been shown using photo mapping that single descending body. So let's say he has a cervical lesion. You can subtract this one, and you can find out where the lesion is. Is it above the myelopathy or what? So like for example, if that man who came just now, he has medulla lesion, right? Medulla lesion. Then you see which part is delayed. Is it this to this or this to this? So you can do that. So but you need normal control. Okay. Anybody else want to try? I think we're running out of time.
Okay.
Okay, thank you to Andre and Andrea. Go over there. Go over there. Thank you. Okay. Thank you. Okay, thank you.
The end of the session.
Yeah.
Thank you.
Go down to Neurosoft and talk to them or
See you tomorrow.